And now we move on to the next session, which is how to investigate a pancreatic head mass, which is a very frequent clinical dilemma. And to deal with this, I have my former colleague from SCBGI, Dr. Sadiq Sikora, who's currently at Sakra Hospital in Bangalore. He is the current president of the Indian Association of Surgical Gastroenterology. And to chair the session, I have one of my former fellows, again from SCPGI, Dr. Arun, who's currently at the Sri Gokulam Medical College in Trivandrum. Arun, please start.
Thank you so much, sir, for the wonderful session so far. And thanks for making me a part of this. It is with great pleasure and happiness that I am able to invite my own teacher, Dr. Sadiq Sikora.
Arun, your connection, it seems to be weak.
Chronic pancreatitis. Over to you, sir.
Okay, Sadiq, please start.
Thank you. Good evening. Yeah, good evening and good afternoon to everyone, various parts of the world. And thank you, Dr. Kapoor, for inviting me once again on this wonderful forum. So as you said, we are now coming to the clinical aspect of chronic pancreatitis, which is, and one of the vexing things is when there is a head mass in chronic pancreatitis, whether it is inflammatory, various other diseases versus cancer. So if you look at almost about 30 to 50% of patients with chronic pancreatitis may have an inflammatory head mass. And a proportion of these may be malignant or may masquerade as malignancy, and you may not be able to get the definitive diagnosis unless you do a resection and final histopathology of this. We also know that chronic pancreatitis is a pre-malignant condition and the risk of cancer is 15 times higher. Majority of the time, the cancer is located in the head, and therefore, again, the head mass presumes great importance in that. Now, if you look at the incidence of cancer in chronic pancreatitis, this first study is from Stanley in Chennai. And they saw, of course, a selected group of patients, almost 1/3 had a malignant head mass. Now, there's a study from Europe, that is Germany and Austria. And there, when they did looked at all the resections over a period of time, they found that 7% had malignancy. And again, from Germany, another study showed 1/3 of patients had malignancy. So there is a wide variation in the incidence of malignancy in chronic pancreatitis. So when you have a mass in chronic pancreatitis, the most important issue which we want to look at and find out is there any cancer in that? And of course, the mass could be those patients with calcification and without calcification, and that puts another sort of issue which we need to contend with while investigating this and looking at possibilities. So the other possibilities which are common in this scenario where there is a head mass is a focal autoimmune pancreatitis, paraduodenal pancreatitis, or the classic mass-forming chronic pancreatitis. And the challenge to the clinician is to differentiate this because each one has a different course, different treatment, and therefore it is important to get a diagnosis. Important to remember that clinical indicators are critical in determining the type of head mass in chronic pancreatitis. So age is important. Elderly people more likely to have cancer. We just discussed about alcohol consumption, which is more in the West, and this alcoholic pancreatitis with head mass poses different challenges. If you have extraglandular involvement like salivary gland or IBD history, then it assumes significance for consideration of focal autoimmune pancreatitis. But more importantly, pain, which is a common symptom of pancreatitis, but when it reappears once there is relief or it changes in character, intensity, duration, then it is a red flag sign. Unexplained weight loss despite enzyme supplementation, new onset diabetes or worsening of diabetes, and then certain complications like jaundice, history of gastric outlet obstruction. So if there are any of these, then you need to look at the patient with a bit of suspicion and go all out to figure out what is is there an element of cancer in these patients. So again, just for these things, the laboratory values are important to look at diabetes control, liver function tests in case of any obstruction, and of course the tumor marker CA19-9. But the workhorse of all these investigations, despite having done ultrasound and other investigations, the main workhorse remains the cross-sectional imaging, which is CECT with pancreatic protocol or an MRI along with an MRCP. And we'll discuss other modalities which would contribute to arriving at a diagnosis in a head mass. So if you look at these pictures, you can see that there is a head mass here with calcification. And then you see a kind of hypo-enhancing mass in this area, which raises suspicion of malignancy. In contrast, you have calcification, a mass with infiltration into the vessel, which becomes rather obvious that you are dealing with malignancy in this situation. Another case with a lot of calcification, but you see a mass in this area with involvement or close to the vessel, a likelihood of malignancy increases. But that's not the obvious scenario in most patients. So this is one way you would be able to differentiate on CT scan between mass-forming pancreatitis and ductal carcinoma. So important things to observe is how the duct is, whether there are associated changes in the duct in terms of chronic pancreatitis, how the calcification is, and the vascular encasement. So if you look at duct penetrating sign, which is very important sign, that is indicating that the duct can be seen through the mass, but there is no obstruction. And if there is other collateral duct changes in terms of side branch dilatation, calcification, then most likelihood this is a mass-forming chronic pancreatitis in contrast to a ductal adenocarcinoma. But if you have calcification which has been displaced due to the growth of or evolution of a mass, if you see a double duct sign wherein both the ducts, biliary and pancreatic, is obstructed, vessel encasement, and then duct to parenchyma ratio wherein there is atrophy of the gland and dilated duct, usually in malignancy, then these are indicators that in this chronic pancreatitis, there is perhaps malignancy. So these are signs which are quite specific for pancreatitis and may have high degree of sensitivity. The other imaging is MRI. Unfortunately, on MRI, when you look at these lesions, most of these lesions, which I mentioned, all four of them, have similar characteristics. They are T1 iso or hypointense, T2 iso or maybe hyperintense, as you can see in this in T2 hyperintense lesion. But the other associated abnormalities are important, like biliary obstruction. And on contrast, this lesion is usually hypoenhancing if you give gadolinium contrast. So this is the typical representation on an MRI. You can see the duct through the mass, and this is the duct penetration sign, which is typical of a benign pathology, which could be any of the benign ones which I talked about. Whereas when you have the obstruction and cutoff of the duct, then it is more likely to be malignancy. If you have biliary obstruction, then MRCP is important. And as you can see by this classification, the last three types, 4, B, C, and 5, are more indicative of malignancy. And these are the pictures. There's a duct cutoff or a double duct sign, which indicate. Now, if you look at the other inflammatory masses which you encounter, which is a focal autoimmune pancreatitis, which is the type 2 variety, wherein only head mass is there. Now, this is the idiopathic duct-centric type. Unfortunately, IgG4 is not raised in this. There is rarely extraglandular involvement, but In 1/3 of cases, you may see inflammatory bowel disease. The characteristic finding is the capsule-like rim halo sign on contrast on cross-sectional imaging. So in this, as you can see, that there is a halo sign around the mass which is present there, and this has very high specificity. If you have multiple skip strictures on bile duct or in pancreatic duct, then it also is a situation where you may suspect that it could be a focal autoimmune pancreatitis. The other entity which now we are recognizing and seeing more and more is the paraduodenal pancreatitis or groove pancreatitis. And now you can see here, this is the duodenum, this is the vessel, mass, and you see this hypo-enhancing area in the groove, paraduodenal groove. So you have a widening and thickening of the paraduodenal groove. You may have calcification suggestive of chronic pancreatitis. And this is the MR sequences, hypo or iso-intense on T1. And on T2 imaging, you can see the cystic or microcysts which shine up on T2 imaging. And similarly on MRCP, duct displacement with microcysts. And these are characteristic features of paraduodenal or groove pancreatitis. So if you have a mass with absent calcification and focal mass, and if you have duct penetrating sign, loss of lobulations, and hypodense fibrotic rim surrounding the mass, then it is a autoimmune pancreatitis. Whereas if there is encasement of vessel, extrapancreatic invasion, duct dilatation, most likely it is malignancy. Now, this is one thing which we keep on discussing, that what is the role of PET-CT in differentiating between inflammatory mass and a malignancy. Now, not much data is available. A lot of studies are there, but they are inconclusive in terms of PET-CT in itself being diagnostic for malignancy. But now there is data coming out, dual point PET-CT, that is early imaging and late imaging. And this is from All India Institute again, which shows that for smaller lesions, dual time point PET-CT is better with sensitivity comparable to a EUS FNAC. So it could be helpful in some scenarios, especially if there is metastatic disease, you may be able to differentiate that. The other modality which has come in vogue in use of a focal mass is endoscopic ultrasound and biopsy. Now, when there is just a solid tumor, it has high sensitivity and ability to differentiate between malignant and benign once you take a biopsy. But the sensitivity goes down much when there is associated chronic pancreatitis, especially the calcific variety, and the sensitivity goes down even up to 50%. Also, in reference to FNA and FNB, if you do a good chunk biopsy, then the likelihood of getting a diagnosis is much higher. So if possible, always do a EUS biopsy in these scenarios. So this is one example that you have a mass on CT, EUS shows that mass, and biopsy shows that it is adenocarcinoma. Furthermore, you can enhance the diagnosis in these lesions by doing molecular diagnosis. And some of these genes like KRAS gene mutation, P16 allelic loss, and DPC4 gene mutation, if you sort of identify, even on a FNA specimen, the sensitivity increases to 100%. In contrast, if there is absence of KRAS mutation in the tissue, then it strongly suggests that you're dealing with a benign pathology. So this addition of this can enhance in difficult situations. There are other modalities like contrast-enhanced ultrasound and EUS elastography, which is being evaluated, has not come into mainstream, and we don't sort of use this as, most often in our clinical practice, and therefore we don't have much experience on that. The other thing is about artificial intelligence in pancreatic head mass. And I think this is going to be a game changer in diagnosing head mass. And one of these studies which has been published, especially looking at EUS, because EUS is so operator dependent, and to sort of read the images, there is a variability in the inter-observer reading. And therefore, this study, which looked at EUS with various AI instruments, comparing whether you can differentiate between adenocarcinoma and a chronic pancreatitis in variable number of patients, and you can see extremely high accuracy in determining malignancy. When you put together all the clinical and other factors together, so this is predictors of malignancy from Stanley Medical College, and they found that bilirubin, CA19-9 at a cutoff of 127, a dilated MPD of 11.5 centimeter cutoff, and a bile duct which is hugely dilated, have high sensitivity and specificity for diagnosis of malignancy in chronic pancreatitis. And similar has been shown by the Cochin Ramesh's group way back in 1992 and then 2009, saying that high bilirubin, short duration of symptoms, duct block, and CA19-9 more than 300 is indicative of malignancy in chronic pancreatitis.
Sadik, 3 more minutes, please.
Yeah. Oh, fine. That's okay. So similar to putting clinical and imaging features together, when you do multi-imaging evaluation, and this study looks at multimodality imaging of CECT, MRI, and PET, and they came out with certain characteristics which would indicate malignancy: a size more than 4 centimeter, Hounsfield unit of 21.8 in arterial phase compared to 37, that is delayed enhancement. And as we talked about dual point PET CT, so in the delayed phase, when the SU is more than or close to 5, and combined together these features, it is more likely to be malignant. So this is the kind of algorithm which you would have. There is a mass in a patient with features of chronic pancreatitis, high index of suspicion because of the clinical issues which I highlighted: jaundice, weight loss, change in character of pain. Then these need evaluation, cross-sectional imaging, biomarkers like CA19, endoscopic ultrasound, biopsy, and if it shows malignancy, then treat accordingly. If it is benign, administer treatment in the same manner. There will be 10% of patients where you may not arrive at a diagnosis despite all this, and there the clinical decision has to be taken to manage these patients. So the take-home messages from how to evaluate this is clinical context is very important. Cross-sectional imaging with CECT, MRI, MRCP is the cornerstone of evaluation. Endoscopic ultrasound and biopsy with molecular markers has the potential to enhance and reach the diagnosis in a large majority of patients. And I feel that AI-based diagnosis will potentially resolve the conundrum of head mass in pancreatitis. Thank you very much.
Arun.
Thank you, sir. Thank you, Sadik sir, for the wonderful presentation on how to evaluate a pancreatic head mass. Lots of points, but beautifully covered in this very short time. And questions from the panel, please.
So, can I start?
May I?
Sir, please.
Okay.
Yeah. So, Sadik, if we have a mass in the head, we don't know whether it is inflammatory or malignant. Some investigations are favoring benign, some are favoring malignancy. Can we be 100% sure and tell the patient that, look, it is benign and it doesn't need resection?
So, as I showed, there are certain features which are characteristic. And if you find those, then you could be certain to a great extent. As I showed that if a combination of certain investigations, including PET with its characteristic features, only by imaging, you may be reasonably certain that you're dealing with malignancy. But EUS biopsy is most importantly required to have a definitive diagnosis preoperatively. And I think with the availability of this in this time and age, I think that should be the final sort of investigation which should tell you. And as I said, that despite all this, at the end of it, you may still have about 10 to 12% of situations where the diagnosis is not certain. And therein, you will need to have a discussion with the patient whether resection is what you need to do, or a drainage still, and see what it turns up. One more aspect which I did not cover because it was preoperative evaluation, is intraoperative evaluation, because you still have a chance to determine whether there is malignancy or not by various features and taking a biopsy at that time. So I think in this time and age, we should be able to make a diagnosis in a large proportion of them, but a small proportion, you still will have to take a clinical decision.
Puneet sir, please.
Yeah, I think this is one of the few areas where we must upfront, before we investigate. Dr. Kapoor's question is extremely valid. We must first tell, we do all this whole plethora and then tell them, and then we turn out to be wrong is also a problem. So we must tell them upfront that we don't know. I think as doctors, we are very hesitant to do that. And this is one area where, I've burnt my fingers again and again and again with all. I've had young patients with all these, high CA19-9s included. And I told them, that it's very likely to be a malignancy. The guy says, I'll commit suicide. I got such severe pain, you operate. So I went ahead with the logic that if it is malignancy, I'm not going to change his natural history. But if it's chronic pancreatitis and I don't operate him and, give him the chance of getting a pain relief. So we told him that we'll take biopsies and, it was not suitable for a Whipple. It had to be extended drainage kind of a situation with head coring. And of course, the frozen was negative, which is probably pointless because you need to take that decision up front. But he had absolutely no features of malignancy. He's been followed up for more than 12 years, with very good pain relief. Many other patients who've been operated multiple times, told it's an inoperable malignancy, come to us. Second surgery has shown it still to be a CP. So I think what we need to know is the clinical conundrum, is what are we going to change in this patient? So the two main places we need to intervene is severe pain and where there's no pain at all and a doubt of malignancy. So, because the problem is if it's only CP, we don't need to intervene. So only when there's a high index of suspicion of malignancy and it's still operable. So this is, this dual equipoise has to be counterbalanced with the fact that most of the patients with both the diseases are probably inoperable for cure. So, putting all that into perspective, I think we should tell the patient up front, we don't know. We're going to look at it. And, even after this investigation, we may still not know. We have a reasonable idea that, it might be malignant, but it still could be benign. And I feel that hope gives the patient a lot of, optimism.
Yes, that's it, sir. Dr. Yogesh, please.
Yeah. So Sadiq, of course, I remember you. I didn't forget about you. I see this whole thing a little bit different. I am very critical towards biopsies because from pancreatic cancer scenario, we would not, if it is the disease is resectable, we tend nowadays not to do a biopsy. So in those cases where you cannot differentiate between CP or PC and the disease is upfront resectable, what change of management are you looking into not to go take this patient to the OR? You can address in such scenarios the chronic pancreatitis with excellent results with an Whipple procedure. Okay. Secondly, if the disease is not resectable, then in the oncological setting, you will have to prove that it is a cancer. In that scenario, the biopsy is mandatory. But in an upfront resectable case, patient with the symptoms, whether only pain or jaundice or whatever, I don't see the necessity for biopsy because it's not going to change the management from a surgeon's point of view. If you want to look into endoscopy versus surgery for chronic pancreatitis, this is different. But as we have heard yesterday and also from the literature, long-term outcome for chronic pancreatitis, surgery is still the best option that is for this patient is required.
So Can I just respond?
Sir.
So, I mean, see, the thing is that in what you are saying holds true in many other scenarios, but chronic pancreatitis, I think, is a different entity altogether. The reason being that you have options of treatment beyond just resection. And it depends what is your threshold for going for resection. And I was last in a debate where I was debating in a head mass, drainage is good enough compared to a resection, of course, after you rule out malignancy. So considering that, there is an option. I know that in certain parts of Europe, resectional surgery is favored over drainage procedures, and there they might have a different outlook towards this. But when you have an option for drainage, and when there is an equivocal kind of situation, I think endoscopic biopsy would not sort of tarnish the oncological issues or barriers, and you could still have one more attempt to establish a diagnosis before opting for either resection or drainage. And I don't agree when most people say, I mean, of course, it depends on what stage you find that, but that, you know, like Puneet added both optimism and pessimism in the same statement when he said that malignancy is incurable, but we should give them hope. But I don't agree that it is always incurable. It depends on in what stage you get them. If you get them in an advanced stage, understandably, it is incurable. But now, with better imaging, I'm sure we are able to pick up more and more, at least lesions which are suspicious, and therefore opt at least for a resection in those. You have to remember that, as Roop Jyoti showed, that incidence of cancer is much less in our scenario as opposed to probably the Western scenario. And therefore, in that situation, we don't see a lot of cancer which need to be resected in chronic pancreatitis. And therefore, we have an option of drainage in these patients. So a little bit of different philosophy, and therefore more attempts to make a diagnosis of malignancy in this.
There are two small questions on the chat. Role of intraop core biopsy. Quick comment.
So, I mean, that is an option. Earlier, there were a lot of issues regarding that, but recently guidelines have come up in how to look at the frozen section in this, and it has improved the ability to diagnose. But targeting is a big problem. If you have intraop ultrasound, you could target it. One of the things we know in this is a core biopsy is better than a wedge biopsy, and a good pathologist is important if you want to take a decision intraoperatively.
Pancreatoscopy.
For diagnosis in head mass, I don't know. There could be a certain situation where there is a double duct sign and you are looking at IPMN as opposed to a head mass causing a malignancy in double duct sign. And in that situation, pancreatoscopy may be helpful.
Arun, concluding remarks before we
just a small point regarding clinical findings to predict a chance of malignancy in pancreatic head mass. The Government Medical College Trivandrum group has proposed one more point, that is first presentation of chronic pancreatitis after the age of 50 years. And as Sikora sir has explained every aspect in a beautiful way, let me summarize by saying signs, symptoms are extremely important. Addition of biomarkers like CA19 will add to the values. Next would be a contrast-enhanced CT. And in any suspicious cases, EUS-graded FNA is going to be, FNA-B biopsy is going to be very helpful. And in still suspicious areas, we can do an additional imaging with an MRI. But let's wait for some more beautiful studies and maybe analysis by the AI series of investigations and artificial intelligence, those things. I think we will get much more answers with a clearer picture in the near future. Over to you, Kapoor sir. Thank you so much for the opportunity.
Thank you, Arun. Thank you, Sadiq. There are two comments from Dr. Puneet Dhar for the sake of delegates. He says that frozen section can be very difficult in many situations, and biopsy has a poor negative predictive value.